So just to reiterate, we're all the affiliation agreements are catching up. We're region-wide. Physicians Council has decided that paramedics need 6 hours of M&Ms per calendar year, and EMTs need 2 hours per calendar year. If you didn't meet your services affiliation agreement standards from 2017, you have until January 31st to get those in. And if you are still meeting the mandates of 2017, this does not count towards the 2018. And you'll have from whenever you get your last one till December 31st to get your standard hours. Does anybody have any questions on the M&Ms or where it comes from or why it's happening? Okay. So in our case one, you're an ALS ambulance dispatch to a male who got burned. It turns out it's a 1-year-old male being held by the mother, standing in the living room. So what are your concerns at this point, thinking about a 1-year-old that got burned? What are some of the things running through your head? Airway concerns, okay, so where are the burns? What else? What did they get burned by? Right, so what are some of the other sticky situations with a 1-year-old and how a 1-year-old gets burned? What are some things we want to suspect in our broader scope as we're looking into it? Abuse, right, good. So we're always going to make sure we strip the patient, look for signs of abuse anytime we have a pediatric. I know the PDR, they strip them every time just to make sure there's no signs of abuse, things like that. So the mother says that a boiled pot of water, she was boiling a pot of water to make hot tea, put the tea in a cup, placed the cup on top of the oven. The patient reached up and grabbed the cup, spilling hot liquid onto himself. So does this change your differential at all? What are we thinking now? So we got to make sure that the injuries jive with the story, right? Yeah. And so a cup's worth of hot water, yes, it's going to create some burns, but better than the entire pot of water from the stove getting pulled off, things like that. So you find a 1-year-old male who's 10 kilos. He's got burns to his face, arms, and chest. He's crying. His ABCs are stable. Grandmother immediately covered the patient in some sort of cream. So, yeah. Butter's better. Smells like delicious, crispy. So you have 10 kilos. That's good, right? Why do we want to know 10 kilos? Okay, fluids. Yep, all our pain management, or our medication management for kids is weight-based. So how do we find out the patient's 10 kilos? What do you guys do when you get a pediatric patient? You can do a Brazel tape, yep, or you can ask. So a 1-year-old, maybe he's had a checkup recently and where they weighed him. A lot of times throughout that first year, they have frequent checkups and they get weighed each time. That way you can keep on top of those things. So face, arms, and chest, how much area is that for a baby? Good question, right? Pediatric infant burns, not something we see a lot. Where would you find some of these numbers pretty quickly? Yeah, which not everybody is up to date on for a baby because the numbers are different because of different proportions. So I know everybody's always on their phones constantly. There's some ALS. There's an ALS flip guide that is got these on it where you just basically hit the parts of the patient that's burned for either pediatric or adult, and it does the calculation for you. It would also do the Parkland formula for you, even though we don't use the Parkland formula anymore for Massachusetts. But just some things to think about. It's kind of one of those low frequency, high risk situations where we get kids that are sick and you know, we may not be completely up to date on some of that stuff because kids aren't just small adults. They're unique in the way that we treat them. So here we go. Face is 9%. There's burns with blistering. Neck, first and second degree burns. Chest, 9% second degree burns. Skin is sloughing off. And the left shoulder has second degree burns to the left arm. So how much are we counting there? Face, neck, chest. Where are we at? Throw out some numbers. Yeah. Good. So significant burns, right? So we have vital signs of a heart rate of 130, respiratory rate of 32, SpO2 is 98%, GCS is 15. Unable to place on monitor due to patient thrashing and movement, applied room temperature sterile water, and pediatric trauma alert to Bay State. So what do you think about these interventions? Seems reasonable, right? Vital signs are good. I mean, I would expect a little bit higher heart rate for a 1-year-old that just got burned. Try to do the monitor. I know it's hard to, if they're thrashing and moving around. So what are some considerations then if the patient is thrashing and moving around and you're not able to assess them accurately? Pain management, yeah, good. So we'll get into that a little bit more, but good. I'm glad we're thinking about that since second-degree burns are pretty painful, especially for a 1-year-old. So how would you transport this patient? How does the state say we should transport these patients? What's that? Yeah, some type of approved restraint device that straps to a stretcher. Most people use a PD-Mate. They're pretty easy to deploy and universally able to click on any stretcher. So patient was transported on the mother's lap. How does the state feel about this going forward? Yes. So basically, crash studies have proven that no matter how much the baby weighs, mom does not have the ability to significantly crash to be able to hold on to the baby. And it's not a safe way of restraining the patient. And any type of decline in the patient, what are you going to do with mom? You're going to tell her, okay, get off the stretcher now. I have to do some more interventions on the baby. So just from that point moving forward, it's a tough situation and it's not approved in our state. So Massachusetts statute requires that children under the age of 8 traveling in a motor vehicle must be secured in a child passenger restraint, aka car seat, unless they are 57 inches or taller, in which case they need to be using a seatbelt. An ill or injured child must be restrained in a manner that minimizes injury in an ambulance crash. Best location for transporting a pediatric patient is on the ambulance cot. The method of restraint will be determined by various circumstances, including child's medical condition and weight. So you have also the patient's car seat that can be used. You want to make sure that the car seat is also applied in the correct manner. You can see how this one's strapped down in 2 different places. A lot of times if you just strap them down in one spot, the head part is tippy. A lot of them have the tether straps on them as well that you can secure. There's a car bed with front and rear belt paths. And then we have the PD-Mate for an example of a pediatric restraint device with 5-point harnessing. And personally, I've even used these on smaller ones and padded around because, I mean, if you have a smaller patient that needs to be transported than what these are rated for, you know, basically you transport them as best you can so that you're still able to provide care, but that they're transported in a safe manner. So they made the patient a Category 2 pediatric trauma. They noted 18% base upper body. They admitted PD surgery service. There was debridement of the slough skin, the antibiotic ointment application as well. So 1753, patient arrived. 1756, patient was given 20 micrograms of fentanyl intranasal. They started a 24 gauge in the right hand. Then they gave morphine, 0.5 IV push, and 200 cc's of lactated ringer bolus. So these are interventions from within the trauma room, right? So are any of these things we could have done in the field? Yes, all of these things could have done in the field. We can understand if, sometimes moving towards the hospital, getting an IV on a 1-year-old might be difficult. But, intranasal fentanyl can be given immediately as soon as you recognize this, and that possibly will help with the further interventions by having the patient calm down a little bit. Why do you think they followed it up with morphine? Yeah, I think that's what I was thinking too. It's since morphine lasts longer, they wouldn't have to keep repeatedly dosing, so a little more of a longer acting opiate. So 11, 12, 17, the patient developed a fever of 102 and then was transferred to Shriners Burn Hospital in Boston. So just a review of our burns protocol. So we've got to remember what type of burn it was, what caused it. Was it a thermal burn or a chemical burn? Thermal ones, we want to stop the burning process with water or saline. So we know, hopefully the family started that a little bit before the application of the mystery cream. Remove smoldering, non-adherent clothing. Don't remove skin or tissue. Cover the burns with clean, dry, sterile dressing. So why are we using clean, dry, sterile dressings? What are infection? They're prone to, why are burn patients prone to infections? It's not a complicated answer. It's not a trick one. What's your body's largest defense against infection? Skin. So if you got widespread blisters and opening up of the skin, then they're going to be prone to infection. So we don't want to just throw any old rag on top of them, but we want to use clean, dry, sterile dressings. Large thermal injuries are susceptible to hypothermia, so attempt to reduce their heat loss. And then with chemical agents, you got to worry about what specific chemical it was and how to treat that. Some should be washed off, some are supposed to be just wiped off. So how can we get some help and information on how to treat those? Poison control, okay. Hazmat. So what do we carry on our ambulances that might tell us first aid strategies for specific chemicals? The big orange ERG book that you might check off on your truck checks but never open in your career. Those have first aid options for all of those things. So make sure you use what's available to you. Again, I'm sure there's an app for that. So get your hazmat app. Yep. Or we'll put up Scott Chapman's phone number. You can call Scott and he'll Google it for you. So just remember, not everything gets water dumped on it. Some things react. So make sure you research what you're doing before you use those interventions. And then at the advanced levels, you can start introducing fluids. Pediatrics, we're doing 20 mils per kilo normal saline. Look at that. So if it's a first degree burn, you have 20 cc's per kilo, greater than 20% of second and third degree burns. Less than 20%, we're given half of the doses for both adults and PD. So you don't have to calculate the Parkland formula. just give that. And our only fluid option is normal saline. Although they'll probably start doing lactated ringers once they get into the hospital. So much easier, instead of having to do the Parkland formula, just to look at basically a liter or 500 for adults, and then we give 20 Cs per kilo for kids normally, half of that if it's less than 20%. So 4,500 vehicle traffic crashes involving ambulances per year, which is estimated. Probably depending on how good the reporting are. 33 people are killed, 34% result in injuries, 44% of patients were ejected from the cot in serious crashes, 33% of patients were secured with shoulder and lap restraints, and 84% of EMS providers were not restrained in the patient compartment. So just think about safety for you and your patient. It may be your restraint, maybe safety for your patient, since you're likely to become a missile in the event of a serious crash. So that's why these numbers are why they keep changing the mandates on our triple K specs for our ambulances, why we have those cross restraints now to make sure people are held better, why we have crash rated mounts to hold our stretchers in now instead of those feeble antlers, which they've known for years do not hold the stretcher in a significant crash. And they're starting to mandate the harnesses for EMS providers on the bench seats, starting, I think ones that were built after July of 2017, they have to have the harnesses on the bench seats. So just think about that, and think about your safety of yourself and the patients. Plug you in. Oh. Hello. You have to talk in here because we're recording and there's a microphone. I would have moved more.
Oh, okay. Sorry, I didn't know that. All right. Hello. All right. Interactive time. What does everybody see here? 2 circles. 2 circles. That's the easiest question all day, and 3 people answered it. So what do you see here? 2 circles. 2 circles. All right. What if I told you one of those is bigger than the other one? And then tell me which one is bigger. Who thinks the blue? Raise your hand. Nobody thinks the blue is bigger? What about the yellow? Nobody? You're ruining my fun display. So, if I told you both of these were the same, would you believe me? Yes, you would. What if I told you they were not the same? In size, not color. They're not the same color, we know that. Same size. You think they're the same size? No? Yeah, think about it long enough. It takes a little while. It's kind of what we think. So they are the same size. They are the same size. Some people think that they're different sizes. Some think that they are the same size. It's all about your perception and what you're told, right? So has anyone ever heard of the culture of safety? Yeah. Yes. Yes. Ooh, words. Good. Making sure everyone's still alive here. So the culture of safety. And what's culture to everybody? From a non-EMS standpoint, what's culture? Beliefs, what you're told, how you're raised, all that's part of your culture, right? So we look at the next picture. Now what do we see? Dinner. Which one's dinner? Both. Both. Jim. Which one do you see as dinner? I'll stand right here. Neither. Vegetarians. What do you see here? Pigs. Pigs. Bacon. What do you see over here? Fido, right? So it's part of our culture that we think that Fido over here, we're going to play fetch with, and Babe over here, we're going to eat for dinner. Right or wrong? Wrong for our vegetarians in the room. Maybe it's wrong. I'll put up a plant next time or so. But it's what we were told. It's how we were raised. We were raised to say we love dogs. This is happy. And pigs are food. Fish are friends, not food. Right? What? We like pigs too, but we eat pigs. But some people, some culture, eat puppies. Right? And cats and stuff. So it's how we were raised. It's what we were told when we were growing up. It's the religion that we follow. It's the language we speak. It's how we act. It's everything. That's our culture. It's what we're told, how we're brought up. So the culture of safety. I'm not going to read that really long, extended definition, but what is the culture of safety? How do you think of it? After you read this, right, read it out, and then tell me what you think of it. Everybody can see it, right? Stand up if you can't, Kenny. Who bends the rules? Us. Right. Why do we bend the rules? Because we're what? Because we're Superman or Superwoman. Right. So we kind of bend the rules because we've been doing this for so long and we're just kind of told, no, it's okay. Don't worry about that. No, you don't need to worry about that. It's okay. Or newer people watch older providers do something and they say, oh, well, if they didn't do it, then why do I have to do it? It's a whole culture thing, just like pigs versus puppies. Complacency kills. We already know that. And if we tell people that, no, don't worry about it. You're not going to get into a crash. You're not going to, hit somebody. Your patient's not going to get agitated and attack you. We tell people this and they believe us because that's culture. We tell them that and they believe us. So culture of safety kind of considers three different things. Risk of harm to providers, which could be what? Give me a definition of risk of harm to providers. Bees. Not wearing your seatbelt, right? That's a risk. If you get into an accident, you're not wearing your seatbelt, what could happen? It's also an easy question. Risk of harm to patients. Stretcher drops. No seatbelts or shoulder straps on patients when you're transporting them. You get into an accident, you're creating a risk of harm to that patient. And then risk of harm to members of the community. What's that entail? Careless driving, right? You're blowing through that red light because no one's ever there. It's 4 a.m. and we're cruising at 60 miles an hour and no one ever comes out. That's that harm to members of the community, right? Or just tossing somebody the bird that, kind of cut out in front of you and you start yelling and swearing at them. They can read your lips. It's also harming the community. So that's kind of what we wanted to touch upon. Does everybody know where this culture of safety came from? What started it? Everybody hear about Chernobyl? Nobody? Nobody knew about Chernobyl? Go back to, yeah. So what happened in Chernobyl? Tell us a story. What happened in Chernobyl? 3 reactors blew up. One reactor and then it all blew up and didn't go so well for them. But why did it happen? Because the people that were operating it, the operators of the nuclear reactors, were not properly trained on the safety requirements of it. And there was no standard set where they wanted to kind of push it to the limit, if you will, and they turned off all the safety features in it. So they could override it. It overheated and then caused that massive explosion, right? So that's where that culture of safety came from, is providing adequate training to the personnel and making sure there's fail-safes, if you will, to make sure that no one else gets injured. Does everyone kind of understand that, follow that? Kind of, sort of? No? So some more just statistics, wow, on it. 22,441 passengers died in motor vehicle collisions in 2015. And more than half of those patients were unrestrained. A lot of people. And 2015, the same study, it was shown that if 2,804 people were wearing their seatbelt at the time of crash, that they would have survived in that impact. So think of yourself as one of those 2,804 people, your family members, your children, anything like that. Those lives could have been saved if they were wearing a seatbelt. But we are complacent and we don't use a lot of seatbelts because we know, that's not going to happen to us. It's not going to hurt us. These things won't happen. So just think about those numbers. We could be one of those 2,000 people. And cue funny cat picture. All right, you guys want 30 seconds to calm down? Want a minute? A couple minutes to relax? Keep going, pushing through. Lively crowd today, huh? Jeez. Okay, case 2. You're a BLS ambulance. You're dispatched for a male with a headache. It's just about 1 a.m., right? What are you thinking about the headaches? What can cause headaches? Alcohol. Somebody say alcohol? Maybe the next morning. All right. All right, so narrative. Can anybody see that? Kind of, sort of? Yes? All right. So dispatch priority 2 for the 75-year-old male with head pain. Arrived on scene to find the patient conscious, alert, and oriented ×3, sitting up in a chair, complaining of right-sided head pain and dizziness. The patient's wife states it woke him up. Patient was assisted to the stretcher and transported semi-Fowlers, vitals monitored en route, arrived at Bay State where patient was transferred to bed via draw sheet, and patient care and report given to RN. What do you think of that narrative? Nothing. What? What else do you think of it? What do you think is missing in there? What could be added in? A lot. Like what? Vital signs, a physical assessment, pertinent negatives. Right. So we all agree that there's some components missing, right?
There's vitals on the report.
Right. In the vital section.
Yes.
So medical history obtained from patient. His history is he has Parkinson's disease and AFib. He's not allergic to anything, and he takes Pradaxa and Cartia. So there's his vital signs we were just talking about. So let's look at those. So at 108, I can use this thing actually. 108, no blood pressure was taken. He had a heart rate of 100, rest rate of 16, his GCS was 15, and his pain was 9 out of 10. They got to the patient's side at 108, and they transported at 120. And at 121, they took a blood pressure at 150 over 100, and then heart rate again was 100, rest rate of 16, a GCS of 15, and the pain scale was still at 9 out of 10. Thoughts on vital signs? What do you think could have been better for this patient? Multiple blood pressures. There should be more what? Right. Your first blood pressure is 14 minutes into the call. After you already begun transporting, you took a pulse rate and respiratory rate, GCS. You didn't take a blood pressure. But we don't know why, because there's nothing else documented in the narrative. Neuro exam, right? We don't talk about nothing, no real physical assessment was done. So if we look at our mass OEMS protocols, we already know our Cincinnati stroke scale. If we look at the bottom here, or one or more sudden acute stroke symptoms. So which one of these does this patient fall into? Sudden severe headache with no known cause. So he woke up with this head pain. He also had dizziness, and his wife said it woke him up out of his sleep. And then he felt the need to immediately call 911. Really bad headache, middle of the night, 1 a.m. or so, and then it woke him up, and he felt the need to call 911. So does this, based on that presentation, does this meet our stroke protocol? Sure does, right. At the bottom one. Sky's blue is Bay State. Sudden severe headache with no known cause. So he got into ED. He presented with a headache. He had some right gaze, some left arm drip, and still had that dizziness. So they worked him up as a hyperacute stroke protocol, and it was determined that his last known well time was the night before at 10 o'clock. So after he got assessed, put in a room, neuro was finally paged at 2 a.m. He was seen at neuro 8 minutes later at 2:10, and they got a head CT at 2:26 in the morning. He did not get TPA. And what do you think is going to happen to his CT if he didn't get TPA? Something's not right in this picture, right? What do you think of that? Bad. Not good. Not good. The big, large portion right here is just, it's a big bleed. So sudden onset, acute headache, no known cause, bleed. So he was admitted to the MICU from the ED. He was deemed non-surgical. There's no interventions that they were going to do. He was intubated, and then palliative care was discussed with his family. He was extubated on 12/13, and then he was placed on comfort measures only and a DNR was signed up by the family. He's placed on a continuous morphine infusion, and then the outcome, the patient expired after this. So what do you think that we could have prevented this massive bleed from happening? Do we think the outcome would have been the same? The outcome most likely would have been the same. He has a massive bleed and he died 3 or 4 days later. But the thing to focus on here is that documentation where there was no physical exam, there's no neuro exam, and then overview of that stroke protocol. Because we miss a lot of strokes because we don't follow that acute onset of dizziness, trouble walking, speech problems, or that headache with no known cause. So I don't think the outcome would have been different, unfortunately, but understanding that we need to document more and we need to realize this, calling stroke alerts. Right? So he got there 2 hours later, neuro was finally paged and he got a CAT scan 2.5 hours later. So if we recognize these symptoms, do a good physical assessment, do a good neuro exam, and recognize this as a stroke, call it in as a stroke alert, we'll move the timetable forward. Does that make sense, everybody? That's kind of what we're hoping for. Questions on that and stroke? No? Nobody? Cat picture? Yeah. All right, case 3. What do we think about this? Now we have to actually talk because now we have real questions, right? What's this? Don't say any EKG. If somebody was. Look at the rhythm and tell me what you think. There's a 12 lead. The next one's a 12 lead when you're ready for that.
Rapid AFib and aberrancy.
Okay, rapid AFib with an aberrancy is on the board. Any other options? Everybody agrees? Melissa? We'll look at the 12 lead. Wait. Is there another 12 lead? 2 12 leads. Everybody still good with the rapid AFib with an aberrancy? Cool. Just another 12 lead, right? Whoa. All right, so this patient, she's a 71-year-old female who believes she is in AFib. On arrival, she found the patient lying supine on the bed. She's alert-oriented ×4 and states she had chest pressure prior to EMS arrival. She denies any other problems. She states she feels her heart beating irregularly. She was secured to the stair chair and then the cot and then the ambulance. Vital signs were taken. EKG showed VTAC with a pulse. What do you guys think? Do you think it was VTAC? You still with AFib?
AFib.
So 12 lead showed wide complex tachycardia, VTAC. IV was established and they gave 150 of amiodarone over 10 minutes. Patient had a change as a result of amiodarone. We're not sure what that change is.
Hypotension.
Yeah. Unconsciousness? No, we're not sure actually. Medical control was contacted for a repeat dose, which was denied. Medical control also stated not to perform cardioversion if warranted. Patient's blood pressure began to drop and Medcon again consulted as patient was still in VTAC. Why do you think their blood pressure dropped? Because they got amio, right? Medcon denied the cardioversion again. Patient continually denied any symptoms during transport and had no change in condition, but you just said that their blood pressure began to drop. So which one was it? They got to CDH, which was the closest they documented. Patient securely unloaded from ambulance, then cot, then hospital bed, and then care was transferred to staff. What do you think about that? What do you think about the narrative and the treatment?
Accurately describes what they believe is the correct course of action.
Good. So if this patient was in VTAC, that would have been good, right? Amio, we love amio for VTAC. Let's look at their vital signs and what they take for medications. A little spout of hypotension over here. They brought it back up though. Well. So patient was seen in Cooley-Dickinson ED and cardizem was administered and the patient's heart rate decreased. That'll do it because why? They were in AFib, not VTAC. So why do you think Medcon denied their second round of amio and not cardioverting this patient?
Medcon will deny anyone when they get the feeling that they're not sure what they're looking at because they're afraid that the paramedic is going to do harm.
Right. So
nothing then too much.
So the medical control that was answering the radio thought that this was not actually VTAC and believed that the paramedic was incorrectly identifying the rhythm, therefore said, no more amnion, do not cardiovert, and bring the patient in. Because the patient was, for the most part, stable. She had no complaints other than feeling that her heart beating fast, and she was normotensive. She had that little spout of hypotension where she dropped down in the 90s, but brought it back up afterwards. So in the ED, they gave them cardizem, and the heart rate decreased. Cardizem, rate control versus rhythm conversion. We know it's a calcium channel blocker, 0.25 mg a kg, and then our repeat is 0.35 mg a kg. We already know all this stuff. We're reinforcing it here. Let's look at VTAC with versus AFib. But why do you think that they thought this rhythm to be VTAC?
It was barren.
This is apparent, right? Like looking at it real quick, you might say, oh yeah, that's VTAC. That's bad. We don't like that. Let's give amnio. VTAC is regular, so it's all in unison. What was not that rhythm? That was not regular at all. So VTAC causes that decreased cardiac output. Sustained is greater than 30 seconds, or any hemodynamic compromise. And then non-sustained is the 3 or more complexes. So you might have a run of VTAC. A lot of people, when they go in for cardiac casts, have a quick run of VTAC, 3 or 4 beats. It's a wide complex tachycardia. The heart rate's greater than 150. And then AFib, the RVR, it's that chaotic repolarization of the atrial muscles. So they're lying, they're fibbing, they're flabbing around. You can't get that complete fill. So that can cause decreased cardiac output as well. Also with these, you have that stagnant blood because the atria is not able to completely dump into the ventricles to push out everywhere. So you sometimes get stagnant blood. So people with AFib are more susceptible to what? Stroke, heart attacks, right? And then no P waves, it's irregular rhythm, right? Beautiful. Questions on that? AFib, you guys did really good with that.
Another last slide.
Yeah.
So
Go for it.
rhythm control versus rate control on rapid AFib. What are we looking for rapid AFib? Which one do we want?
Roll it down.
Control it, slow it down. Okay. So we talked about our med of choice that we use for that is cardizem, which is a calcium channel blocker. So how does a calcium channel blocker slow down their rate? Anybody? Wheeler?
It does just that. It blocks the calcium channels, and calcium blockage, it reduces contractility and conductivity of the heart.
All right, so everything we work in our muscles are electrical actions. So we have different electrolytes change size in a cell, and it changes the polarity of that cell, causing muscles to fire. Same thing in the heart. So when everything changes size and changes the polarity, it causes a depolarization or a contraction in that muscle. Then when there's a relaxation, it all goes back to where it started so that it can fire again. So you have your P wave is the first little blip we see in the EKG, which represents the atria contracting, which you're not going to see in AFib because the atria is not all contracted together. We see that fibrillatory baseline typically. And then we have the QRS, and then we have the T wave. What happens in that T wave?
Repolarization.
That's where everything's going back and get ready to fire again. So there's 2 parts of that. There's the absolute refractory period in the first part, where any signal, no matter how strong, cannot cause the heart to fire again. Then you have the second half, which is the relative refractory period, where a strong enough signal can get through and cause the heart to fire again before it's ready. So a lot of times when you see that ugly Y aberrant conduction, is because you literally in AFib have hundreds and hundreds and hundreds of signals trying to fire and get through. And your junction there is kind of like the bouncer at the door saying, nope, nobody in yet until somebody comes back out, things like that. And so that's what cardizem is helping with that. It's lengthening that absolute refractory period so that it's longer before a signal can fire again, and gives a chance for the heart to catch up, slows down, takes off some of the demand. So what are some of the challenges of people who are in AFib every day? What do they lack? Does somebody in AFib have the exact same cardiac output of somebody who is in a sinus?
No, and
No.
they also don't have an intrinsic rate control in the same sense that somebody that is intrinsically starting from the sinus has.
Yep, so they have rate control problems and they have decreased their cardiac output. Why do they have decreased cardiac output? No atrial kick. So typically you have the atria squeezing and having the ventricles filled the rest of the way. So part of the ventricles are filled with passive, where the valves open up and allow the blood to drain. And then there's the end part where the atria actually squeezes and pushes the rest in. Then the other part of that, when you get that squeeze and pushing the rest of the blood in, Starling's law says that the ventricles, the more they're stretched, the harder they'll contract up to a certain point. So people in AFib can be up as much as 30% less cardiac output because of being in AFib. So then you add on top of that, their heart is also going 150 to 200 times a minute, and now they're not getting as much filling time because it's going so fast. You're going to start having ischemic chest pain. You're going to start having possibly hypotension, start having chest pain, things like that, where you're seeing them symptomatic, and we need to control their rate. We don't want to necessarily convert them. So why wouldn't we want to convert them? You might throw a clot. So you got these atria that are quivering for years. They're mostly on blood thinners to try to reduce that. But if you start getting the atria to start contracting on their own, they could definitely sense the clots down the line and cause either a stroke or a heart attack. So this is why in rapid AFib, we want to look at this. And there are times when, when you have a variant induction and you're not sure one or the other. I mean, the faster it goes, the harder it is going to be to tell when basically how irregular it is. I mean, if they have a heart rate of 200, it's not going to be as easy to tell because they're all scrunched up together. So we have to kind of weigh the pros and cons. How sick is this patient? Are they more bad than good, more good than bad? What are you thinking about which med we pick up because, putting all the stuff together. But,
I was recently told by a cardiologist that if you're debating on SVT with an aberrancy or AFib with an aberrancy versus VTAC, the easy way to do it is to look on a 12 lead in the initial V1, V2 leads. And if they're positively deflected, that's typical of ventricular tachycardia. If they're negatively deflected as normal,
yeah.
that would be supraventricular.
Yep.
Pretty
So,
simple.
yeah. So try to think about, there are times, we had a rapid AFib came into the ER recently that had a trial of cardizem, and they decided to cardiovert right away because the patient was having prolonged ischemic chest pain. So in our protocols for rapid AFib, it talks about going to cardioversion if they're unstable, but it specifically says unstable if their blood pressure is less than 100. It doesn't allow you the other things that ACLS allows for other types of instability. So we're trying to clean up some of these protocols when we go to the medical services committee meetings. We have a list of things to present of kind of ambiguous protocols or protocols that are not as wide as they should be. There was a time in our protocols where they referenced the ECC guidelines and allowed us to change as AHA changed, but then we're kind of handcuffed now that they took that back out and on their own idea of instability. So just think about some of these things. Are they more bad than good? Is there, are they having that ischemic chest pain? That's the other thing. Don't get sidelined by the chest pain and think, oh, they're having a heart attack and that's why the heart's fast. Think about which came first, the chicken or the egg. Are they having the chest pain because of the rate, or is the rate in response to the chest pain? So lots of things to think about, when we're given these meds, and just try to think you got a fast heart rate. Are you going for rhythm control, or are you going for rate control? And then, think about how your meds work and how you want to fix them, and always have a backup plan as well, to whether or not you want to try to cardiovert, as always. So we, at our facility, We review all of the Signal 600s that come in. We listen to the report. We look at the chart, we look at the run forms, we try to find out was the orders correct. You know, for those docs who are, you know, too shy to actually say yes over the radio, they get feedback from the attendings on, you know, whether they should give it. I think third-year residents are the lower level of who can answer the radio. So it's third-year residents and up can answer the base state. So we listen to those and we try to find out, should MedCon have said yes, or why did the MedCon say yes, and what things can we put in our report that can help identify that stuff. So any questions on that stuff, or any issues you guys have had with calling for orders or things? So we're trying to, we have radios in every pod now. We're trying to make sure that the time to Signal 600 is as short as possible. I know in reviewing calls last month, like 20 seconds was the average. You know, so they're trying not to make you wait 5 minutes for a MedCon and things like that. So let us know if you got any problems or anything that, you know, you got questions that, you know, keep asking us for feedback when you have calls so that you know what happened and helps you treat next time in the future. Hey, Rick?
You're just talking about.
Yeah.
Hey, it's me, Destin, and welcome back to Smarter Every Day. If you've ever been stung by a jellyfish, you know that it's awful. Let me show you. So there's two ways that an animal can harm a human chemically, right? The first one is poison. We know what that is. Like if I were to eat this jellyfish and it was poisonous and I were to get sick, it's because it is a poisonous animal, right? Now venom is different. Venom is injected into your body. So it's kind of like these hypodermic needles. If you fill them up with venom and then you were to take that and inject that into your arm, that would be a venomous way of causing pain to your body, right? So wouldn't it be crazy if there was like hypodermic needles built into their tentacles and they could just stab you with them as soon as they rubbed up against you? Because that's exactly what happens. Jellyfish tentacles have organelles in them called nematocysts. They're like little hypodermic needles. And when you're swimming and those hypodermic needles brush up against your body, they stab into you and inject venom. It's insane. People have never seen these because they're so small you have to have a microscope, and they're so fast that you have to use a high-speed camera. So now that we've rounded these two things up, where do we find our jellyfish? Check it out. I'm at James Cook University in Australia, in Cairns, and here's the deal. I've got the doctor here that's the world expert in animal venom. It's pretty cool. Let's go check it out. His name is Dr. Jamie Seymour. So we have a high-speed camera here, and we're running HD SDI video out, and then Richard is recording it real time, and then Dr. Seymour here is going to try to trigger a nematocyst, correct?
Correct.
And then once you trigger it, we're going to try to catch it on high speed.
Yep. So if you look at an anemone, we've just taken this out of an anemone, and if you poke it in the sides,
So this isn't a jellyfish.
what's related to jellyfish?
Close enough.
Yeah.
Okay, I told everybody wrong. I said we're going to learn how jellyfish sting you.
Well,
This
it's the
isn't-
same thing. It's the same process.
Oh, is it?
It's like saying, okay, we're going to work out how a bullet works today. Here's an AK-47, and then if I walk in with a Glock, it's the same process.
You are speaking my language, Australia,
See,
man.
there you go.
There you go. All
So we're
right.
still not exactly sure what causes the nematocyst to fire, but what we do know is if we touch two leads from a 9-volt battery to the tentacle itself, we can get some of them to randomly fire, which allows us to record it with a Phantom high-speed camera.
Trigger.
There it goes!
Trigger. How long have you been trying to capture that?
Well, we've been doing it for a fair number of years, but we've never had the camera technology to actually do it at this level before. The nematocyst, which is a cell organelle, so it's inside a cell, which is a ball with a wound up hypodermic needle in it. And we saw it basically discharge. So
And the
that-
needle is not rigid necessarily.
That's correct. Think of it like a garden hose under
Okay.
no pressure, and then when you apply pressure to it, the whole thing straightens out.
Got it.
So what we saw there, it's the whole thing fired off. You got some sort of idea of how quick that was.
Right.
But the thing that blew me away was the time lag from when the thing discharged to when we saw the venom.
Yeah, it was like a third of a second.
Yeah, we've
Yeah.
never seen that before. I mean, we've seen venom come out the end of these things.
Right.
We've never seen that delay, but we've never looked for it.
You're digging this, aren't you?
Oh, this is cool. This is like real science. This is the sort of stuff I get up in the morning for.
Are you implying that I don't do real science?
No. You do the same thing. There are times you get up in the morning, I'm sure, and you just go, I so want to go to work today because I'm going to find out something new.
Right.
Isn't that why you do it?
Right. It is.
I mean, seriously, I would do this stuff for free.
Yeah.
It's the joy of actually coming and going, I just saw something that nobody else in the world has ever seen before.
It's kind
Or
of
I just
selfish.
learned something. Yeah, but then you can teach people about it.
That's right. Yeah.
And that's, I
do.
Look, I've got goosebumps all over me just from that sort of thing. It's great. It's exactly why I do this sort of stuff.
All right. Well, thank you very much. That's Dr. Seymour, venomologist.
Toxinologist!
Toxinologist!
Oh,
I'm never going to get it right. So from now on, when you think about jellyfish, I hope you don't think about just slimy tentacles dragging poison on your skin. It's actually an organelle called a nematocyst containing venom that takes it and actually shoves it into your body and then injects the venom. I'm just kidding, I didn't actually squirt that in me. But that's pretty intense. I hope I didn't ruin the beach for you. The people at James Cook University asked me if I would inform you that they are looking for undergrad and grad students. They need people to help them figure out how to solve the box jelly venom mystery. It's a cardiotoxin. It kills the heart, but they don't really know how or why. So if you're interested in studying, go to James Cook University. I think their motto is like the Explorers of the Tropics, which is pretty cool. Anyway, I'm Destin. Go check them out. Have a good one.
The big box jellyfish things have got 800,000 of those things per square centimetre.
Really?
That's how small they are. Not only do you get to learn about the animals, but we physically put you in the lab and give you venom. And go, here's some rattlesnake venom, or some box jellyfish venom, or some other venom. And you get to use it on heart cells or blood and things of that nature, and actually physically see the venom doing its thing there and then.
Really?
Not too many other subjects allow you to do that, for a whole variety of reasons.
So is this unique to James Cook University?
Absolutely.
Yeah. And you started it?
Yeah.
That's pretty cool.
It is.
Little
It is.
pride in that, huh?
Just a lot. Yeah.
So just to reiterate, we're all the affiliation agreements are catching up. We're region-wide. Physicians Council has decided that paramedics need 6 hours of M&Ms per calendar year, and EMTs need 2 hours per calendar year. If you didn't meet your services affiliation agreement standards from 2017, you have until January 31st to get those in. And if you are still meeting the mandates of 2017, this does not count towards the 2018. And you'll have from whenever you get your last one till December 31st to get your standard hours. Does anybody have any questions on the M&Ms or where it comes from or why it's happening? Okay. So in our case one, you're an ALS ambulance dispatch to the male who got burned. It turns out it's a 1-year-old male being held by the mother, standing in the living room. So what are your concerns at this point, thinking about a 1-year-old that got burned? What are some of the things running through your head? Airway concerns, okay, so where are the burns? What else? What did they get burned by? Right, so what are some of the other sticky situations with a 1-year-old and how a 1-year-old gets burned? What are some things we want to suspect in our broader scope as we're looking into it? Abuse, right, good. So we're always going to make sure we strip the patient, look for signs of abuse anytime we have a pediatric. I know the PDR, they strip them every time just to make sure there's no signs of abuse, things like that. So the mother says that a boiled pot of water, she was boiling a pot of water to make hot tea, put the tea in a cup, placed the cup on top of the oven. The patient reached up and grabbed the cup, spilling hot liquid onto himself. So does this change your differential at all? What are we thinking now? So we got to make sure that the injuries jive with the story, right? Yeah. And so a cup's worth of hot water, yes, going to create some burns, but you know, better than the entire pot of water from the stove getting pulled off, things like that. So you find a 1-year-old male who's 10 kilos. He's got burns to his face, arms, and chest. He's crying. His ABCs are stable. Grandmother immediately covered the patient in some sort of cream. So, yeah. Butter's better. Smells like delicious, crispy. So you have 10 kilos. That's good, right? Why do we want to know 10 kilos? Okay, fluids. Yep, all our pain management, or our medication management for kids is weight-based. So how do we find out the patient's 10 kilos? What do you guys do when you get a pediatric patient? You can do a Brazel tape, yep, or you can ask. So a 1-year-old, maybe he's had a checkup recently and where they weighed him. A lot of times throughout that first year, they have frequent checkups and they get weighed each time. That way you can keep on top of those things. So face, arms, and chest, how much area is that for a baby? Good question, right? Pediatric infant burns, not something we see a lot. Where would you find some of these numbers pretty quickly? Yeah, which not everybody, you know, is up to date on for a baby because the numbers are different because of different proportions. So I know everybody's always on their phones constantly. There's some ALS. There's an ALS flip guide that is got these on it where you just basically hit the parts of the patient that's burned for either pediatric or adult, and it does the calculation for you. It would also do the Parkland formula for you, even though we don't use the Parkland formula anymore for. So just to reiterate, we're all the affiliation agreements are catching up. We're region-wide. Physicians Council has decided that paramedics need 6 hours of M&Ms per calendar year, and EMTs need 2 hours per calendar year. If you didn't meet your services affiliation agreement standards from 2017, you have until January 31st to get those in. And if you are still meeting the mandates of 2017, this does not count towards the 2018. And you'll have from whenever you get your last one till December 31st to get your standard hours. Does anybody have any questions on the M&Ms or where it comes from or why it's happening? Okay. So in our case one, you're an ALS ambulance dispatched to the male who got burned. It turns out it's a 1-year-old male being held by the mother, standing in the living room. So what are your concerns at this point, thinking about a 1-year-old that got burned? What are some of the things running through your head? Airway concerns, okay, so where are the burns? What else? What did they get burned by? Right, so what are some of the other sticky situations with a 1-year-old and how a 1-year-old gets burned? What are some things we want to suspect in our broader scope as we're looking into it? Abuse, right, good. So we're always going to make sure we strip the patient, look for signs of abuse anytime we have a pediatric. I know the PDR, they strip them every time just to make sure there's no signs of abuse, things like that. So the mother says that a boiled pot of water, she was boiling a pot of water to make hot tea, put the tea in a cup, placed the cup on top of the oven. The patient reached up and grabbed the cup, spilling hot liquid onto himself. So does this change your differential at all? What are we thinking now? So we got to make sure that the injuries jive with the story, right? Yeah. And so a cup's worth of hot water, yes, it's going to create some burns, but better than the entire pot of water from the stove getting pulled off, things like that. So you find a 1-year-old male who's 10 kilos. He's got burns to his face, arms, and chest. He's crying. His ABCs are stable. Grandmother immediately covered the patient in some sort of cream. So, yeah. So we need your help so that this isn't extra boring and painful. So throw out answers, no matter what level you are. We can all answer, talk about it, questions, things like that. That's how we work through these things. It's all for educational purposes. Nobody's gonna laugh at your answer. If they do, they're laughing with you. So we got an ambulance that was dispatched to a skilled nursing facility for an unresponsive patient. So the call was received at 14:08, dispatched at the same time, en route at the same time. It was very efficient. 13 minutes to get on scene, 4 minutes to get to the patient's side. Quite a bit of time to transport, and then half an hour transport time. Oh no, 16 minute transport time. So your call facility for unresponsive patient. Upon arrival, found patient was on CPAP. Staff stated patient's O2 sat was 100%, but she felt she needed the O2. Patient not responding to a sternal rub. Monitor placed, vitals attempted. Patient with sinus on the monitor and breathing without difficulty. Patient obese, hard to get good vitals. Patient has dialysis in the right upper chest and much help from staff. Patient slid to cot and moaned when moved. Patient was moved to the ambulance and en route to ED. 12 lead was done, noting sinus rhythm, abnormal EKG, unable to get a good PO2, O2 at 12 liters per minute given. Patient transported without further incident to Bay State Medical Center, room B3, report given to the MD and the RN. So some notes from this was patient was obese and hard to get good vitals. Patient not responding to a sternal rub. Patient on CPAP. Vitals were attempted, 12 lead done, noting a sinus rhythm and but an abnormal ECG, and unable to get good PO2. So O2 was given at 12 liters per minute. So what are some thoughts? So we start with a wide differential of everything that could make someone unresponsive, right? And then we narrow it down as we get information. So what are some differentials that this could possibly be, and what more would we want to know? Okay, so we want to know blood sugar. So diabetics could be a reason for unresponsiveness. What else? Could be a narcotic problem, yes. Have we ever seen a skilled nursing facility that may have administered too many narcotics and not recognize this? Frequently, absolutely. What do you make of the CPAP part of it? Right. And why do you think this patient has CPAP? Yeah, they're extremely obese patient. I've had some patients that literally need to be on CPAP all the time because their mass prevented them from breathing adequately on their own. Hard to get good vitals. I mean, is that really, what are some other options if you can't get, vitals, blood pressures, pulses, things like that? What are we going to try? Bigger cuff? Put the automatic cuff on the forearm, maybe? You're going to put a manual cuff on the forearm. You got to listen below the cuff. We've seen people put a cuff on the forearm and then listen in the regular spot above it. It doesn't work. So
Maybe some old school methods of skin side, cap refill.
there you go. Yeah, right. Cap refill. So what's that? Yeah, get a pressure by palp. And if the person doesn't have a peripheral pulse, that's going to tell us a lot about their circulatory status. So a lot of things you could put together. If they don't have good peripheral circulation, you have poor cap refill, they're going to have cool, clammy skin, things like that. So combative patients, we can always get a respiratory rate on, even if they won't let you touch them. So just remember, there's other things. And outside of these classic vital signs, a lot of people use the SpO2 as a pulse checker. And so if your SpO2 isn't reading, they don't know how to get a pulse. So we got to think about that. So what are some reasons why SpO2s don't read very well? Yeah, cold extremities, patient with poor peripheral circulation. So, if you don't have a good pleth wave there, that means it's not seeing enough and you're not going to rely on that SpO2. So our vital signs, blood pressure of 153 over 112, pulse of 92 and weak, respiratory rate of 18, SpO2 94%. Then blood pressure went to 204 over 143 on the automated. I don't see a blood glucose in here yet. What do you think about these blood pressures? Yeah, so you got all automated cuff blood pressures, and then they're through the roof. So what could be a problem with a blood pressure cuff that'll give an errant high reading? Wrong size. So how are our BP cuff size? How do we tell if they're too big or too small? So you ever notice there's like an arrow on the cuff, and then on the other side of it, there's that white bar. So when you put the cuff on, if that arrow doesn't fall in that white range, then it's either too big or too small, and you're not going to get a good reading, and especially not going to get a good reading with an automated blood pressure cuff. So one of the problems of always relying on an automated blood pressure cuff is you may not have a proper blood pressure to start with, so then your trending afterwards is going to be off. So they do have a weak regular pulse. SpO2 94, 89. So so they noted a GCS of 4. So this patient, what do you think about somebody who's completely obtunded with a GCS of 4? Probably need some aggressive airway management. Start with an NPA, maybe go to OPA, go up from there, depending on what's another vital sign that can help us tell their ventilatory status and how aggressive we need to be. Capnography, good. So lung sounds were documented as normal. BGL was not documented or not performed. So one of our first differentials we thought about was diabetic. Sugar may have been done, but it's considered not done if they didn't document it. So the H&P was that it was patient has CHF, dementia, diabetes, peripheral vascular disease, renal disease, obesity, seizures. Physical exam was documented and assessed with no abnormalities. Skin condition and temperature not documented. So we talked about that as our alternative vital signs of telling what their status is at. So in the emergency department, patient came in responsive, hypotensive. Emergency department administered 0.4 of Narcan. They gave push dose epi, push dose epi of 10 micrograms. They gave some fluids. They intubated, started on pressors, and they had a point of care of 78. So sugar's decent. No effect on the Narcan. Why do you think they gave epi and fluids and pressors? Blood pressure. Okay, so what are some reasons they could have been hypotensive and had blood pressure problems? What's our differentials for that part of it? So say they got accurate vital signs and they were hypotensive. What are some things you're thinking they could be hypotensive from? Sepsis. Good. Sepsis. So what else? With sepsis, you got dehydration. You got basically severe sepsis and septic shock, where they have that peripheral vasodilation, and they have the increased vessel permeability. So basically all the fluids leaking out and not in the right places. The body's trying to get what volume it has to save the vital organs. So peripherally, you're not going to have good circulation, which is going to lead you to why the SpO2 didn't work. So a patient was in septic shock, white blood cells of 35.2 thousand, admitted to the MICU. Hickman catheter for dialysis was accessed the Hickman catheter was likely the source of the infection, but they're not exactly sure. Patient was placed on comfort measures only, and the patient ended up expiring. So again, some of these things, the mortality level of a patient in septic shock is 80% right now. So 80% of the people who get that far end up expiring, so our interventions are very important. There's time-based interventions for sepsis now. So we're doing awesome on STEMIs. We're doing better on stroke alerts. Now we're moving on to sepsis alerts because they're finding a lot of people who normally are healthy individuals are dying from otherwise reversible causes. So patients who get an infection, they ignore it, then it gets worse, they start getting septic. So the beginning level of sepsis, they start with like a 10% mortality, and then it continues to go up. And then there's a study that shows with severe sepsis, every hour that goes by, their mortality goes up by 7% every hour goes by that they don't get antibiotics. So some states are drawing blood cultures in the field and then using pressors and a lot of aggressive fluid managements. And some are giving broad spectrum antibiotics out in the field as well, because this is such a time sensitive situation. So just something to think about. I mean, we do have our protocols related to septic shock. So we used to go by the Sears criteria. Now there's the SOFA and QSOFA. So the SOFA they use in the hospital, and it's a sequential organ failure assessment. So it's basically an assessment of how far this systemic problem has gotten, measuring different parts of the body and different systems. But we can do the QSOFA, which is pretty easy. So we're looking just basically heart rate, presence of infection, respiratory rate, and blood pressure. So if they're hypotensive, they got a high heart rate and a chance of blood pressure, those two things are like a 40% mortality already. So we need to be aggressive with these types of patients. Anybody who has an infection and has abnormal vital signs, we've got to be thinking sepsis. And then how do we relay this information to the hospital that this is time-sensitive illness is happening? Sepsis alert. Thank you. So you're increasing the level of suspicion on the hospital side of how sick these patients are, and they're going to see them quicker because they know that how valuable that process of, they have like a 3-hour window that they try to get all these certain things done, and they're called time-sensitive interventions. And so we're trying to bring down. They did a study like maybe 8 years ago, I think, and there was like 800,000 cases every year of sepsis, and 200,000 of those people are dying. So in a country this advanced, people are getting infections and dying because they're not being recognized quick enough and they're not being treated aggressively enough on our end. So they're already behind the curve when we get them. So we need to have a high index of suspicion. We need to call in that sepsis alert, and we need to start aggressive fluid management, but also think about if you get a patient who's hypotensive, it's not very long before you need to start pressors if they're in septic shock, because their blood vessels are already open and dilated. You need to, in conjunction with fluid resuscitation, clamp them down peripherally as well to try to get that blood pressure. So our mass protocol, so we identify it. So there's still they're still using the SIRS criteria from the last iteration of these protocols, but the QSOFA and the SIRS, we can use together. So there's warm sepsis and cold sepsis. So not everybody who has septic shock has to be hyperthermic. There are some people who have who are hypothermic. So if they have a temperature of less than 96.8 or greater than 100.4, if their heart rate is greater than 90, SIRS has bumped that up to 100. QSOFA bumped it up to 100. Respiratory rate is greater than 22 beats per minute, which I think is the same as QSOFA. Systolic blood pressure less than 90, or a mean arterial pressure of less than 65. So 65 to 100 is like your range of what you want. If they drop below 65, so some monitors you can set that, so when you do the automatic blood pressure, it calculates the map for you, because I looked it up like a month ago and I don't remember again how to calculate it. So that's not something we do a lot, but just keep in the back of your mind, if you're using pressors, if your fluid resuscitation doesn't work and you're using pressors, your goal of over 65 is what you're looking for. Then we're looking for new onset altered mental status or increasing mental status changes. Serum lactate levels. So some places are doing a special project waiver where they draw a lactate level. So that's one of the markers that is the hallmark of sepsis. However, they've done studies that show that a end-tidal CO2 of less than 25 correlates with a lactate level of 4 or above. So we don't have to run out and get lactate machines. We already have capnography on the ambulance. So we talked about capnography earlier when we thought it was a respiratory patient, but it would also help you in the presence of infection, because what kinds of things cause lactate levels? You mentioned sepsis, but what's a lactate level come from? So when you're working out and you get sore the next day, what's the cause of that? Acidosis. Yeah, it could be rhabdo if you do CrossFit, right? When I was doing a rhabdo M&M, all I could find was CrossFit memes for rhabdo. All right, so you work your muscles to the point where they go past aerobic metabolism to anaerobic. So now they're using other things to make energy, which byproducts of that are acidosis. So now you have patients who have poor peripheral circulation because they're in septic shock, they're hypoperfused. And so now you have all this stuff collecting out in the peripheral tissues because you don't have enough circulation to offload all that CO2. So now you get CO2, your low expired CO2 is not because they're hyperventilating, it's because they don't have enough circulation to transport all that off. So that extra CO2 that stays in the peripheral tissues, that goes and it binds and it makes H2CO3, which is a weak acid that's in the body, which can start creating havoc on your end organs. So now you have this acidosis that's happening because of a poor circulation. So we're trying to increase their circulation and get more blood flowing peripherally so that we can get all this toxic stuff out and then we can get it out. And that's where bicarb comes in handy, where bicarb breaks it back down to H2O and CO2 so they can absorb the water and exhale the CO2. So this is why this is all happening, and these are all different tools you can use to assess them and figure it out. So as was mentioned, we want to do our routine patient care and then notify them of a sepsis alert prior to arrival if we can. That helps. Some hospitals are having a sepsis protocol, so when they hear a sepsis alert, they do have certain actions. Some hospitals who don't have a coordinated effort also will hear sepsis alert on your radio report and then use that when they're finding a room for you and how quick they get them in and then how quick a doc sees them after that. So some things we can do better is better airway protection. So you got a obtunded person with a really poor GCS. Try to think about more ways to adequately secure their airway. Even if we use an OPA and a BVM, at the BLS level, that's better than, just leaving, like Jimsy talked about, they're unresponsive. So, if you got your medic, I don't remember how long CPAP's around, but, probably more than 8 to 10 years, we were used to intubating unresponsive people. And then CPAP came and it kind of became the fix, and people only ever saw CPAP, had them on there. And I've seen people slumped over on CPAP because they figured it's like, kind of a ventilator. But, they use two different mechanisms. So if they're unresponsive and they're not breathing adequately on their own, the CPAP isn't going to help. They need positive pressure ventilation. So we need to be better at that, better at our vital signs. So we talked about, there's not, we got the core set of vital signs that we use, but there's other things that we can use to help, describe a better picture of how sick this person is. So obviously this person was pretty sick, and, some conventional ways of getting vital signs probably didn't work. So we have to be able to describe other things, and then make sure we document our blood glucose. I mean, it didn't end up being the problem, but, that's one of our main vital signs for someone who's unresponsive. And it quite possibly was checked. It just wasn't documented. So any questions on that? So ALS ambulance dispatched for unresponsive patient. Got your times here. So call received, dispatched en route, all 9:27 to 9:28. They were on scene 17 minutes later, 16 minutes later. Outpatient side 3 minutes later. They transported 16 minutes on scene, and then they had a 20-minute drive time, and care was immediately transferred. So there was a primary impression of neurologic unconscious unresponsive patient. So your primary impression is unresponsive again. So what's our differential diagnosis? What do we got? What's an acronym we have that we use to think about? What are your list of possibilities on unresponsive? We talked about it. We've mentioned a few of them, but AEIOU tips, that's a good one. So what are some of those AEIOUs and tips? What's A? Alcohol, good. E? Epilepsy. I? Insulin. O? Overdose, which goes with U, underdose. And tips? Trauma. I? What was the last case? Infection. P? Starts with a P but doesn't sound like a P. The psych. And the S is shock, right? All right. So patient's wife states that he had a slight confusion yesterday, was ambulatory around the house last night, went to bed and was found this morning unresponsive, vomited, called 911. Patient was found in bed, unresponsive with respiratory rate of 8 to 10, pinpoint pupils. He has an insulin pump, fentanyl patches on the right shoulder. EMS check versus vital signs. BP initially is 104/30, heart rate of 69, respiratory rate of 10. Point of care was 205, placed on stretcher, O2 mask, 15 liters per minute. With, what's NCL? Extricated to ambulance. Chest, some bronchi diminished in the right, the left lower right lobe. Abdomen soft, no masses, upper, lower, flat, extremities were flaccid, unresponsive to pain. Rule out aspiration, unresponsive. ECG, normal sinus rhythm. 12 lead was not a diagnostic. Automated BPs, inaccurate. Manual BP range from 104/30 to 99/40. IV 20 gauge in the right hand. 20 nasal trumpet inserted into right nostril, O2 15 liters per minute. Capnography, monitor patient respiratory status, and route to Bay State Medical Center. So what do you think of this one? Yeah, it's hard to read. Yeah, that stands out, right? So that's in our differential. Possible overdose goes with the pinpoint pupils. How about the
Diminished breath sounds with respiratory rate of 10. Why don't
good question? We did at least get a nasal trumpet this time, so
yeah,
we're getting better.
it's measured in French, not
Yeah.
French millimeters. 2 centimeters. Big one.
Maybe this could be an ambulance from Canada. You know, we don't know. All right, so they did identify that the automatic blood pressures were inaccurate, and they did the manual ones, so inaccurate, which is another good thing. So we're a little bit better. So we kind of narrowed down our differentials, right? So we talked about possibly overdose with fentanyl, and then we talked about diminished lung sounds. So what are we possibly thinking with that? Yeah, or they documented that they're questioning aspiration. So you know, maybe they had reason to believe there was possible pneumonia going along with this. So maybe they left out in their report. Well, they did say they vomited in bed. So maybe they're thinking, but again, which came first? Yeah. So it could be aspiration pneumonia on top of something else. Maybe they vomited for a different reason. Maybe they're unresponsive from the fentanyl patches, then vomited and got aspiration pneumonia. Now it's like anything. So history is obtained from the family. Patient has a history of cardiac disease, hyperlipidemia, hypertension, congestive heart failure, and COPD. So that's a tough combination of CHF and COPD. No allergies. They're on insulin. Head was symmetrical, no JVD. Symmetric with bilateral chest rise. Abdomen was soft and non-tender. Pelvis was stable. Back was symmetric. Extremities fully intact. Purposeful movement. So purposeful movement, little more than initially. I think they said the extremities were flaccid. So the EMS treatments was 15 liters per minute by a non-rebreather with no change. So if we give 15 liters a minute and there's no change in the patient status, what are we thinking? Yeah, more aggressive management. We talked about positive pressure ventilation, maybe more than an NPA. EKG was done, vascular access of a 20. You know, we don't know what the patient looked like, but I'd say, you know, try to get a bigger one or a second one. But maybe the patient was poor access. That's something to document as well. If you should have, you know, been given more aggressive fluids and you couldn't get more than a 20, then document patient's poor access. Just paint that picture so that people who are reading it afterwards can understand what your thought process was. So alter level of consciousness, they gave a nasal airway, which did not change anything as well. Pulse ox, 91% on O2. And then vital signs were all transferred. So here's our 12 lead. Pretty much unremarkable. I'd expect somebody with low SpO2 and unresponsive to be a little more tacky.
CMed the Bay State for priority 2. CMed the Bay State.
Bay State AMI 407, honey, copy. We were in routine facility with a 61-year-old unresponsive male patient. Wife states the patient was confused yesterday. He does have a history of diabetes with a insulin pump, and he was found this morning unresponsive and vomited in his bed at some point. Initially, had a respiratory rate of about 8 with a heart rate of 67 and a blood pressure of 160 over 100. At this time, patient has a nasal trumpet in. He is on 10 liters of O2, 12 liters non-diagnostic. He's got a capnography of 40 at this time and a heart rate of 67. He remains unresponsive. Blood sugar is 205, and got a history of some type of cardiac, some CHF, COPD. Lungs appear clear in all fields except lower right. He is diminished, and we got an ETA of about 5 minutes.
So in the emergency department, patient arrived, got a room 4 minutes later. Blood pressure was 84/37. He gave push dose epi again, intubated using ketamine and rocuronium. No epi drip was established, and they were transferred to ICU. So you think this was an overdose? Yeah, possibly sepsis again? Yeah. So have that differential continue to be wide. Try not to get tunnel vision. Patient's diabetic and they're unresponsive. It seems like they were focused on that. Patient's got a respiratory status. I didn't see if they had tried any Narcan, but it would have been nice to try some Narcan to see if there's any change. The other thing to think about too is lower brain strokes can cause pinpoint pupils as well. I've seen people stroking out and gave a bunch of Narcan to them and absolutely no effect, in their being obtunded and things like that. But then came out that they were having a lower brain stroke, which can cause pinpoint pupils as well. So don't try not to get tunnel vision. Try to keep your differentials open. And if you try something, it doesn't work, try something else. Try to, keep trying other things or look further in your assessment to try to rule out some things or rule in some things. And so patient was admitted to ICU, elevated white count of 22,000, lactate at 3.5. So kind of on the borderline sepsis. 4.0 is usually where they call it sepsis, but this patient was probably getting to that point. So it was good that they were able to brought to the hospital before that can happen. The other thing, depending on when they got the lactate level, one of the things you want to see from fluid resuscitation, if you can measure lactate, is that the lactate will go down once you start fluid resuscitating them. So depending on when they got the lactate level, if they had some fluid beforehand, it could have brought that down. Also, pH is 7.06. So, starting to get sick. The body likes a very specific pH. So sepsis and aspiration pneumonia. So they were close on their assessment. They got what the problem was, but the follow-up on that probably could have a lower threshold for aggressive management for these patients. So patient ended up doing well, extubated, weaned off pressors, awake in the ICU, slightly elevated white count. So what do you think are some things, knowing what we know now about sepsis, what we want to maybe try in the field a little more aggressively? We got our primary sepsis interventions that we can give. Fluids, all right. And what if our fluids aren't working or they're in septic shock? Pressors, good. And how are we telling the world that we possibly have this going on? We're doing a sepsis alert. Good. So we want to think about 2 lines if possible. You just can get a 20, get what you can get. Especially if it's your first line, you want to get some access and then try again on the way to the hospital. If you don't have enough hands, call for more help. call for another medic if you're working in a PB scenario, you need some help. These patients we talked about, they have a very high mortality. The longer they wait to these interventions, the worse their mortality gets. So we need to make sure we treat them aggressively and then be more aggressive with your airway management. If they're completely obtunded and unresponsive and they're not breathing, they're breathing 8 to 10 times a minute, those are people that need help. So they're probably a combination of the hypoventilation and the sepsis caused their end tidal CO2 to be 40, which can be misleading at that point. But just remember all these things when you're going forward. So these are all emails. We have cards if you need them, but reach out to us if you got questions, you want follow-ups. You had a problem in the ER. A lot of these things can be fixed very quickly because they're misunderstandings. So please don't hesitate to reach out to us or reach out to your local affiliate hospital medical controls that we have. And any questions, comments, concerns? All right, thanks for coming. Thanks for participating.